Happy Friday. Happy Friday. It's Dr. Unati here, your host. I am back. It's a Friday, 2:15 p.m. Eastern Standard Time, 12:15 p.m. Mountain Standard Time. Of course, it's a beautiful Friday in Calgary, in Canada. I have a beautiful panel for you guys. I see people are coming on. Welcome, welcome, welcome. Bring your hobbies, bring your family, bring your colleagues. This discussion, it basically applies to everyone. So I would like you guys to bring everyone on. I have this powerhouse panel for you. Today, it's kind of unique. We're going to have a deep dive discussion. So please take your seat, get your drinks, and join us. Again, welcome, welcome. As you can see, our topic today is breast cancer awareness. I have this panel for you. We're going to talk about people with lived experiences. I have right to my right here, I have Dr. Edith Mudrav Stewart. She is a surgeon. She's a general surgeon who specializes in breast surgeries, vascular surgeons, and of course, surgeries, and of course, varicose veins. She's gonna talk more about herself. Next to her is Dr. Susan. Dr. Susan Malsa is also a specialist in America here down south. She specializes in rehab, basically in physical medicine. Below her is Dr. Freehill. Dr. Freehill has a lived experience, you guys. She's an orthopedic surgeon, and she's going to share with us here how she actually survived. Being a survivor today, we are so grateful she's here. She's going to share her experiences. And next to her is Dr. Moira. She's here with me in Canada. She is a medical oncologist. Welcome, ladies. Can you please introduce yourselves to my people here?
I will go first. Hello. Like Dr. M said, thank you so much for having me, and thank you for the intro. I am Dr. Angela Freehill. I am an orthopedic surgeon in the Midwest, in a little town east of St. Louis. I am a mom of 3 beautiful girls. And like she said, I am 5 years out from breast cancer. So I will tell you my story in a little bit, but thank you so much for having me.
Thank you so much, Dr. Angela. Anyone can go second, ladies?
I am Dr. Edith Woodruff Stewart. Like you said before, I'm a general surgeon. And so I do gallbladders and hernias and all that kind of stuff. But really, breast cancer patients is really my passion. I practice in the Central Valley, which is the mid part of California. I know it's a gigantic state, but I practice right in the middle of that state. I have a husband and 2 sons, one 15, one 7. And I want to thank you for having me on your panel today, and tell the other guests it truly is an honor to be on the panel with you. Thanks.
Thank you so much, Dr. Edith.
Hi, I'm Dr. Susan Maltzer. I live in New York and I practice here. I'm a physiatrist, which is a rehabilitation medicine physician. And I specialize in something called cancer rehabilitation, which is basically taking care of any problems that patients can develop after their cancer and cancer treatment. And I'm really excited to be on this panel and to learn from you guys and to talk about all things breast cancer.
Thank you so much, Dr. Susan. Dr. Moira.
Hi, I'm Dr. Maura Rushton. I'm a medical oncologist. I specialize in breast cancer. I'm based in Ottawa, in Ontario, in Canada. I also do research and work with the Canadian Cancer Trials Group, and I also am a proud mom of 2 young kids who are 6 and 3. So thank you for having me. Nice to meet you all today.
Thank you so much, ladies. And like I said to our viewers, thanks. I can see you guys are on here. You know what, Dr. Freehill, as we know, when I was looking at our stats globally, we have 7.8 million people who were diagnosed just at the end of 2020 who are living with breast cancer in the last 5 years. And I was so shocked when I looked at this 680,000 people who died of breast cancer just in 2020. How did your journey start? Do you want to share with our community here?
Yeah, so I was a busy mom of 3 girls. My twins were little miracle IVF twins. They were 3 years old, and my oldest was 9. And I was a busy surgeon. I was a busy mom. I was just in the middle of life. I was 43 when my twins were born, and 47 when this all started for me. So I never had breast cancer on my radar. It was not in my family. I knew about it from medical school, but did not have a lot of experience. But I had some young friends of mine diagnosed, so I kind of knew about it, knew about it, but didn't really ever really thought about it for me. So, Labor Day weekend, I was just in the shower on a Thursday night. I had been having some soreness in my left upper chest. I thought I had pulled a muscle. We had just gotten back from Florida, but I was just doing a self-exam in the shower, and right where I had my soreness, I felt a lump, and like cold sweat. I just knew, because I was 47, healthy, nothing on my radar. I didn't think it could be anything else. So I was very proactive. It was a Thursday night. I called my doctor on a Friday. I pulled the doctor card. I said, I need to get in a mammogram. I need a diagnostic. I need an ultrasound. I need a biopsy, because I just felt off. I felt something was not right. I had pain, and this lump, I just felt like it was really something bad. So it was a surgery day. It was Wednesday. I got in for my ultrasound and mammogram. That was a 1 centimeter little grape-sized mass right at the top of my breast, and it was kind of right adjacent to my chest wall, and I think that's why I was having pain. And the radiologist said, this is nothing. This looks like a fibroadenoma. You just don't need to do anything about this. And it was a crossroads for me. I just was kind of convinced already in my head that I had breast cancer. And he said, just come back in a month. I know you're busy today. Just don't worry about it. And it was just did not hit me right. And I said, no, we are not doing that. You are going to do this biopsy today, because this doesn't feel right to me. And I really had to fight for myself. And he said, you're very persistent. I said, yes, I am. This is hurting me. This is not right. I don't think this is something that's okay. I could see that little mass across the room on my mammogram, and I just said, it's not okay. So he did all of this. He had to leave the room and get all the pre-certs and all the things, but we did the biopsy right then. I was an hour and a half late for my surgery day, but I didn't care. I was standing up for myself and trying to get treatment. And the next day, nobody called me. I actually called the pathologist myself and said, hi, it's Dr. Freehill. I have a personal question. I know you have my biopsy on the desk. And the pathologist was not super friendly. He just said, yeah, it's cancer. You gotta get some treatment. And so there it was. So I got my hormone factors back, the markers back. It was triple negative. Every day while I was waiting, I could feel that lump getting bigger. So I just jumped into action. I got myself an appointment for the surgeon, the breast surgeon. I saw her within 10 days or so. We made plans. It was stage 1 at the time, triple negative. So I needed surgery and chemo. So, it was earth shattering. You are facing down the barrel of this diagnosis. You don't know how you're going to do. You don't know your staging. Luckily, I was very lucky. I had stage 1, no spread, no lymph nodes, I did the CTs and we didn't get a PET scan because the insurance said no, but I had a CT of my chest and abdomen and pelvis. It was all negative. So I was very lucky. So I underwent a bilateral mastectomy. That was my personal choice. I'm sure not everybody makes that choice, but I was, I'm kind of a type A anxious kind of person. So I chose that for myself. And then chemotherapy is the treatment of choice for triple negative. I got 2 different opinions, and I elected to stay locally. We have a fantastic cancer center near me at Barnes in St. Louis. I did my 4 cycles of chemo and, lost my hair, went through all of it. So, it was a pretty quick treatment course and pretty quick experience for me. But of course, the effects are long lasting. And I guess the takeaway from my experience is that I'm lucky that I knew what was going on. I'm lucky that I fought for myself. My staging and my outcome very well might have been different had I not fought for myself. So I am passionate about spreading awareness about breast cancer. I feel like it's the most important thing to have women understand that no matter what their age or what their experience, we're all at risk. And to stand up for yourself in the diagnostic process, and don't let anybody tell you that you don't have a choice or you don't have a voice, because we all have a voice in our own treatment. So that's my short story, and I'm happy to share it.
Wow. Dr. Angela, you're amazing. And of course, we're happy to see you here sharing such a powerful story. And you know what? You have a unique story because you were already a physician who knew who could stand up for herself. Many women out there are unable to do so. And as you can see, you took it right by the horn and went with it, which is very unusual. You know what, Dr. Edith, can you please take us through what are the risk factors? She said a lot of things right here, but I would like you to go back a little bit and basically let us know what is it that we need to know about the risk factors and, of course, the symptoms, like she said.
Right. I just want to say for a moment that, I'm so glad that Dr. Freehill, that you stood up for yourself. And you could just imagine you were in the inner circle. You had, the personal phone numbers and you knew how to work the system. But we're doing some spotlights on some patients that I've operated on this year. And I'm finding out that more and more of these patients have had to really, really advocate for themselves, push themselves through the system. They don't have any of the sort of inner things that we have. And so that sort of saddens me, but tells me that there's a lot of work to be done in that space, that we need to start taking women seriously. We need to start asking more questions. And we, as physicians and as patients in general, we need to be prepared to have someone come with us that can advocate for us if we don't think we're strong enough to do it on our own. So, yeah. So thanks for that story, Dr. Freehill. You asked about risk factors, Dr. M?
Yes, let's get it.
So all the ladies on this panel today have a risk factor in that we were just born female. So just being born female and having the privilege of getting older puts you at, a risk there. And just there's nothing that you can control about that. Then there's a subset of patients who have genetic disorders. Probably the most common we've heard of is the BRCA1, BRCA2. We've identified those genes. Probably the most famous person you've heard would be Angelina Jolie in her fight with having the BRCA gene. And then we have patients who we haven't identified the genes, but they may have a first degree relative, first degree being mother, sister, kid, daughter, or even male that has had breast cancer. Those are first degree relatives. So we haven't really identified all the genes that go with this. We know about BRCA1, BRCA2, but if you've got a family, if you got a mom and two sisters that had breast cancer, we know there's something going on there. We just haven't identified and named it. Doesn't mean that, you're not at risk. Those are things that you probably can't even change. Obviously you can't change. The other part of this, we know that the longer the estrogen and progesterone circulate in our body, we know that puts us at higher risk. So if we start our periods before 12, or if we end our periods, much later, we know that there's a longer stretch. If we have someone who has fewer pregnancies than a person that maybe has a lot more, a nun versus a person that's had 10 babies is going to be at higher risk. So we know that those people that are exposed to their own hormones are at a little bit higher risk. And then we have those things that are lifestyle factors, those things that we can do something about. And we know that people who smoke, who drink alcohol, who are overweight and who use, in some cases, hormone replacement therapy, we know that they have a higher risk as well. The first set of factors I talked about, not much you can do about in terms of changing those, where you are. But the last set, those lifestyle, those are things that we should all be encouraged to work with and use to decrease our risk of getting breast cancer.
Absolutely. Thank you so much, Dr. Edith. And of course, me as a family physician, this is I'm usually the gateway for people to get to you guys. Usually it's through physical examination, or in the case of Dr. Freehill, she found a lab. It's a partner, people say, what, my partner who found this lab. And of course, I would like to also talk about, like you mentioned, all the risk factors, and you mentioning genes. Dr. Moore, I know at the end, people come to you. I'm going to let this ball bounce between you and Dr. Edith, because, of course, when she's done doing the staging, Dr. Edith, do you decide to go for surgery? Dr. Freehill talked about her staging here. When do we decide for chemo, for surgery, for radiation? I'm going to let you go on that one.
Thank you. Yeah, so I mean, for any patient with early stage breast cancer, being stage 1, stage 2, or stage 3, we would include surgery in the course of their treatment as a curative intent, meaning that we are planning to try to cure them so they have long-term survival, just like Dr. Freehill. The decision about the timing of surgery is made based on the subtype of cancer and the stage, and also an assessment by the surgeon whether or not the tumor is operable upfront or not. So someone like Dr. Freehill with a small, or like a stage 1 tumor are less than 2 centimeters. So that's a small, typically easily operable tumor. Those patients often will go straight to surgery. For patients with stage 2 or stage 3 cancer, like if she had a higher stage cancer of triple negative variety, which we can talk about more, those cancers often will go for chemotherapy or sometimes targeted therapy before surgery to, shrink the tumor, make the surgery easier and less disfiguring. And also in 2 of our subtypes of breast cancer, the triple negative and the HER2 positive, doing what we call systemic therapy, which includes chemo before surgery, can actually improve long-term outcomes because of the information we gain at the time of surgery. Because when we treat someone before surgery, when they go for that operation, if they've had all of the complete response to chemotherapy and there's no tumor left, that's amazing. We know that person is going to do very well. If they didn't, though, then we have the opportunity to treat them differently after surgery. So, typically the patients who get upfront treatment by someone like myself would be higher stage, like stage 2, stage 3, either triple negative, HER2 positive breast cancers, or those who are truly inoperable upfront, or what we call locally advanced or inflammatory. There's a lot of different terms out there to describe some very similar things, which can be confusing for patients, but that's kind of the decision making. And in terms of who makes those decisions, it's often shared in a multidisciplinary setting between the medical oncologists and the surgeons. And I know at my center, we work very closely together, and we have close working relationships, and there's a sort of established community of practice within us, and there's international guidelines on these topics as well.
Right. You know what, Dr. Mora, I'm glad you're mentioning the interdisciplinary committee or groups, because there's a lot of emotional involvement in this. There's lots of emotions. People are scared for their lives. They keep coming back to us, their primary care physicians. Am I going to live? Yeah. Am I going to survive? You know what? Dr. Freehill has a unique story. She already had kids. I would like you guys to comment about what are the chances of fertility after all of this, because things happen so fast. And I'm going to get to Dr. Susan, because that is a very important part, because people want to know what's next. After all of this, what is my future, doc? That's usually the question people come back. That's the most thing that makes them not to sleep at night. Dr. Moira, want to take that one?
Sure. So, I mean, the chances of fertility specifically on that topic after surgery, it really depends on a lot of individual patient factors. The biggest factor is, from a patient factor, the biggest factor is your age going into treatment. The older you are going into cancer therapy, the less likely that you'll have your ovaries survive. There is a big push now for pre-chemotherapy, pre-treatment fertility counseling. So if you're speaking to a patient, that's a question they have and their provider has not brought that up, they should be asking and advocating for themselves, saying, this is a priority for me, because it sometimes gets lost in the rush to get to treatment and it's forgotten. And if the patient doesn't raise their hand and say, this is important to me, people might forget. It's a busy time. So it's important that patients advocate for themselves in that manner as well. Fertility treatments, unfortunately, are quite expensive and not always covered by insurance plans or publicly funded in Canada. But there are also some charitable organizations that will help patients. For patients that are interested and don't have the option to undergo like fertility preservation before treatment, they can take, there is medication we can use to put people's ovaries to sleep as one form of extra protection. In terms of the likelihood of pregnancy after breast cancer, there's definitely increased risk of infertility and decreased chances of pregnancy and that's been consistently shown, age-matched individuals. And even for patients who do not go through chemotherapy, many patients in breast cancer will undergo hormonal therapy, and that too has been linked to decreased fertility for various reasons. It's a rock and a hard place though, because the reality is that your likelihood of fertility will be decreased, but by the time you're sitting in that office with a cancer diagnosis in front of you, it's not the time that you can start planning a pregnancy. So it's a lot about counseling, and if there's an opportunity for fertility preservation and pre-chemotherapy fertility assessments and preservation, that's the best thing patients can do to protect those chances moving forward.
Right. Yes. I mean, you're right. And I've seen the speed that is required to act. And we can't run away from the fact that women now are career driven. People want to wait a little bit longer. We're seeing women now waiting till they're 35, 36. There's been quite a remarkable, waiting. And it's amazing for people when they could plan. But now how do you decide? And like you said, it's expensive to also preserve those eggs. Now, Dr. Susan, a person has all the surgery, has had all the chemo, they're coming to you fatigued. What are you seeing? And I would like to see, because I think somehow there is some, I must say, even from our end as family physicians, we tend to basically be the ones who are looking after these patients. I was so excited to know that there's basically room for them to see someone to deal with all these complications that come with it. So I'd like you to share your thoughts. What are you seeing and how are you managing our lovely ladies when they come to you?
So first I want to say that, the number one thing is we have to make sure that our patients are fit and healthy before they have surgery. So your preoperative function and your exercise capacity and your shoulder movement, all will definitely help after surgery. But I would say the most common things that I see are post-mastectomy pain, which is common in probably 40% of patients undergoing mastectomy. Lymphedema, which is a condition that causes swelling in anybody that's had a lymph node removed, and can also be, about 30 to 40% of patients who have breast cancer. Fatigue during chemo, neuropathy, aromatase, and aromatase inhibitors, joint pain. So those are kind of the things that we see in cancer rehab medicine, and try to control pain, improve shoulder function. For patients that have any kind of radiation, improve radiation fibrosis, do a lot of education on lymphedema, on risk factors, on what to look out for, how to treat. And really, we tend to kind of put ourselves in that survivorship bucket that, we follow a lot of these patients for a long time after they're done with treatment.
I love that because it changes life. I've had my patients say, Doc, you cannot take my blood pressure on this arm because I have lymphedema, that swelling you mentioned. So, sometimes when you are not living the experience, you could easily overlook this. And I don't want us to talk, I don't even want to miss talking about the mental health aspect that comes with it, the changes. Unfortunately, Dr. Angela is unable to share her story here because there's also the sense of loss. I don't know, you guys, you can comment on that one. What are you seeing, most especially Dr. Edith, when you're going to do that mastectomy? It's going to change life. People would have all these changes, and when are they going to go back for reconstruction? There's so much involved.
Absolutely. There is a lot involved. And I can say it's very hard for me to predict what by age or by race or anything, what a patient may want. They are very different. I literally saw one of my 30-year-old survivors yesterday, and she says, I don't want reconstruction. I may wear the prosthetic bra, but I'm not sure. I'm a ballerina. I don't need those things anyway. But, in the distant past, I've had an 82-year-old patient who wanted reconstruction. So I think that, like you said, Dr. Freehill can kind of speak on how women feel about their breasts, how it works with how it fits in with their femininity, how their husbands or partners, what their opinions are. I think all of that goes into the decision for surgery. Most of my patients, for the most part, they can have a choice between getting a partial mastectomy or a total mastectomy. And some patients even take it further and kind of like Dr. Freehill say, you know what, take both of these off and let's just start over with something else. And so patients, there are a lot that goes into that. And you talked a little bit about mental health. I see patients because I'm oftentimes a person who tells the patient that they have cancer. So I get an up close look at sometimes it's disbelief, which they can then flow into denial. Then there's some anger. They move through all of those stages in different ways in different times. And I will say that without a doubt, mental health is incredibly important in the healing process. That's something it's hard to quantify, but I see it in my patients that maybe don't have the best support systems, maybe don't have such a positive outlook in life in general. In general, I say they might not heal as well or in the way that a patient that has a lot of support, that has a positive outlook, is ready to fight. I definitely see a difference in the way that those patients heal.
Yes, absolutely. As a family doc, I see this all the time. And also the speed of seeing the surgeon or of being sent to Dr. Moira. Now we deal with COVID-19. Can you guys comment on that? How is COVID-19 affecting the whole thing, the whole process? And before we do that, Dr. Freehill, we wanted to hear from you. How was it for you when you decided on that mastectomy? Emotionally, how did it affect you, your self-esteem, and also your partner, like all that perception? I would like to hear from you on that one. You're muted.
Okay. So that's actually a really important question and something that is kind of a process and not an easy answer. So I was very fearful of my cancer spreading and dying from my cancer. So I, because it was aggressive and because it was growing, I just did not want the risk of recurrence. And my surgeon gave me all the options. We could have done lumpectomy and radiation. We could have done single mastectomy or bilateral. And I just was risk averse, and I wanted to do the most I could to avoid recurrence. So for me, the personal decision was bilateral mastectomy, and I'm happy with my decision. I feel like it was right for me, but it was not an easy decision. It was not an easy process. emotionally, physically, sexually, mentally, all of those things were, it was a difficult transition. It was a difficult adjustment because your body is different. Your body has changed, and it does not have, it's just not the same experience. So I can say that I'm, much better. I've gone through a healing and a grieving process, which I think is normal for any survivor. My husband just would much rather me be alive and in the family than to, have breasts that look a certain way. So he does not care at all. And that was very gratifying. It took a while for me to understand that it didn't matter to him as much. But we're good. I mean, it's been a very good process for our relationship. It has actually strengthened our relationship, which I think is great. Reconstruction for me, I didn't know what I wanted to do. I was worried about breast implants. I was worried about the DEEP procedure, which is the transfer of arteries and tissue. I didn't know what I wanted to do. So I waited for 2 years before I had reconstruction. I ultimately elected implants just because it was easier. I have a busy life, like I told you, and I wanted kind of the lower maintenance procedure. But I kind of regret that. I think had I go back and do again, I would probably do the epigastric flap procedure if I ever did it again. But that ship has sailed. So, it's just a super personal decision. And for me, it took me a long time to really decide on reconstruction. And, to me, it was just more important to be aggressive with my cancer treatment than anything else.
Yes, that's beautiful, Dr. Freehill, because, and that the biggest part I find it's that support. Like Dr. Edith was saying, the support when you don't have it at home and you also have an unsupportive spouse, because we've seen women coming back sooner wanting that change. So really it's and I'm glad actually, Dr. Mora, you have it in your team to have those social workers, the psychologists, the counselors to do this work, because coming to us, it's not enough. And I mean, we become, as a primary care physician, you become a counselor, you become a psychologist, but it's not enough. They need to have that phone. And what I like about the oncology clinics is offering them the number to call that person when they have those questions. I find it's a very good support, because practically, really, you have them at night, you're not sleeping, And of course, Dr. Freehill, you did mention hair loss. That's a big one. I would like you to comment on that. And also, Dr. Mora, what is out there for people? Because I see also people wearing wigs, and also it comes with another layer of, there's a whole lot, there's judgment even out there. I'd like you guys to comment on that one.
Well, for me, I mean, hair loss was actually harder for me. It was harder for me. I felt like it was a very public experience to have my hair be gone, as opposed to the private experience losing my breasts. People don't know what's going on underneath your clothes, but if you walk out in the world, they can see if you don't have hair. So I have long hair. I've always had long hair. So showing up to work after my cancer experience and having no hair and wearing these little beanies, and it was harder for me than anything, actually, just because I had to explain it to everybody. And people comment, your patients and your coworkers, they don't know what's happening with you. So you have to be prepared to have your explanation, or be prepared with what you will and won't share with people. And that hair for me was really difficult, because it was just a public expression of my illness that I wasn't maybe ready to share with everybody. So I have kind of translated that into something else. I've kind of started a beauty company, and I work with people on hair growth and hair restoration. And so it's just a side thing for me. But it was part of my cancer journey that I have done that. So for me, I took some of that difficulty and made it into something more, productive and beautiful for me. So
Beautiful story, Dr. Priya. By the way, your hair is beautiful. I love its color too. So rich. It's lovely. I mean, some people, it doesn't come back. And I've seen also, I would like actually Dr. Mora to comment on this, because I've seen some of my patients telling me, you know what, my hair is curly now. It's curly. It used to be straight. Can you comment on that? And of course, I'm talking about now people who like yourselves, you guys, you have straight hair. I've never seen that in my own people that look like us, Dr. Edith, but there's some changes. How is that transition?
Yeah, it's definitely, you're correct in what you've seen in your patients. We do see that. And I even tell patients, unfortunately, all the standard chemotherapy which we use for breast cancer leads to hair loss. And even hormonal therapy can lead to hair thinning. And that's really frustrating for patients. And, as the state, as long as we're still relying on these cytotoxics for treatment, that's probably going to be the reality. And it is very personal. Exactly what Dr. Freehill said, that is what my patients tell me too, is that this hair loss is now public signaling. And patients sometimes will like, oh, I don't want a wig. And then they're like, actually, I do, because I don't want to have everyone in the grocery store know what I'm going through. Not just your family or friends. I mean, in her, in Dr. Angela's case, her patients, she probably doesn't want them to know everything she's going through. And yeah, when your hair grows back, it doesn't always grow back the same. It'll change texture, it'll change colors, and there's no way that we can really predict that. Some patients think that's kind of fun. Surprise, what's my hair going to look like? And, trying to look for the silver linings there. But hair loss is a deeply personal thing, and it really affects people's, sense of who they are and sense of what they look like. So it's really tough and very part of the emotional journey.
Right. Yes. And I would like you guys to comment about, do you find sometimes, because us family physicians, we find our patients sometimes not wanting to share with their kids. They're trying to protect them, and it becomes quite complicated how much you want to share with your children. And when they are little, in the case of Dr. Freehill, if you're okay with that, you can share with us, what age. I would like to hear on that aspect. And of course, Dr. Susan, I want you to share with me this journey when they come to you. Is there that support kids? Are they involved? Because they also scared to lose their family or their father. I mean, we're gonna talk a little bit about men here, but that journey with the kids, when do you share? What is your advice there?
So I think, when we have patients that come to us, we really try to understand what their support network is, what their support system is. By the time most people come to us, they're like done with their cancer treatment, or they're in the middle of their cancer treatment and they've already had those difficult conversations. I think the bigger challenge becomes is that patients kind of think like, oh, I just have to get through my cancer treatment and then I'll be back to normal. But for a lot of patients, when they get through their cancer treatment, they're really like rock bottom, and we have to build them up a little bit. I think in that regard, just greater awareness that there are rehabilitation specialists out there who specialize in cancer will go a long way, because so many patients come to us and they say, I've had this pain all along and nobody knew what to do with it, and we can figure out relatively quickly and we can treat it. So I think, kind of just spreading the message that there are physicians and physical therapists and occupational therapists that kind of treat this subset of patients. And then, just being sensitive to the fact that this affects every aspect of a patient's life, right? Like their work life, their sexual life, their relationship with their kids, their relationship with their friends. So that's definitely something that we try to support and help them with.
Yeah, it's very smart. I mean, I'd still want to hear from Dr. Mora, because I've had patients coming back to me. You've had the conversation with them and they still don't want to share with their kids. When do you see that transition? And of course, Dr. E, you can also chip in, because that decision, if you don't want to share with your children, then how do you explain your mastectomy, right? When does that happen in your practice? What do you see? What is the age group people are comfortable to share with their kids?
I find that it's so different. I think people that have really little kids, they don't always want to share it with it because they don't want to, let's face it, you have to face your own mortality, and that's pretty scary. I see I've seen also kids that say like at the middle school or high school age, people will share maybe part of it. Maybe they'll come with their partner and then decide what to tell their kids. I had a patient recently who didn't want to tell her adult kids, and she had an adult son who was a radiology tech, and then his wife was a nurse in recovery. And so it actually kind of put a little bit of burden on us because we need to use x-rays, you need surgery, you need a lot of things that are involved, with the hospital. And so how are we hiding this and why? I like to know, wait, why are we hiding this from our adult kids? And it's not just kids. People go into this planning that they didn't anticipate on who to tell, what to tell, how much to tell. And that's probably very stressful as well. But I see patients with kids of all ages kind of trying to work through it. And, ultimately as doctors, we really don't know how long people, are going to live, or even if we can kind of estimate how long they might live, we don't know in what fashion, are they going to be still up and able to run after a ball, or, are they going to be prostrate? We don't know those things. And so those things are very difficult for patients to understand and then transmit to kids and other family members. I'd imagine that's very stressful, and I know that some of the other panelists probably have seen different things too.
Yes, Dr. Moira, do you want to say something about that? Like, I mean, you want to start your patient on chemo and radiation, and there's resistance because they don't want to share with their kids. How do you navigate that, Dr. Moira?
Yes, I mean, I would say that I haven't seen a lot of resistance in terms of not wanting to go through chemotherapy because of the disclosure piece. But I mean, there are other reasons that patients don't want to go ahead with treatment. And I think that's a challenge that we all face in medicine, is that we offer patients that we know have good scientific evidence that improving outcomes. And at the end of the day, patients don't want it. I mean, in my own practice, I have to say that I really view my role as the person to educate patients on what their options are. And I do my best to ensure that they do understand and appreciate the treatment options that are available to them and what both the benefits and the risks of those treatments are. And if someone decides not to pursue the treatments that I've offered, I mean, I will usually try more than one way and set up a follow-up appointment and try to understand where they're coming from and the reasons what it is. But there are always a few patients that just decide that they don't want treatment. And, I feel like I have to respect that. And it's both because I think patients are autonomous to make these decisions, as long as I feel like they have had the education. And also, we can't force people. And if as providers, if patients decline the treatments we've offered them, if you really, so I really do view my role as more of a person to educate and offer people treatment. And as patients, it's the patients who make the decision, because if I own that decision and they just decline it, then it's really caused a lot of moral distress on your providers as well. And I don't find, perhaps they're not telling me that they're declining treatment because of their children and the disclosure. And maybe that's more something you're seeing in your practice. And maybe it's just because they're not telling me. The most common thing patients say to me is that, well, I don't want chemotherapy. I say, well, nobody wants chemotherapy. Like, this is not, nobody comes to me and says, give me the chemo. This is not what people want. And I wish we had better treatments to offer people, and people will look at it's important for people to look at the numbers, and because numbers mean different things to different people. If I tell someone this reduces your risk of recurrence by 5% or 8%, that means a lot to some people. And I've had other people who that doesn't mean enough to go through with it. And they say, no, it's not worth it for me to lose my hair. to the risks, to, everything. And it's a really individual decision, just like the surgical decision is individualized. And so we really have to do our best to educate our patients on what they're actually signing up for. And they have to make those decisions. Because at the end of the day, I'm not going to see this patient for more than a few appointments over the course of a few years, and it's their life.
Right. Yes. You know what? We're going to close here, ladies, soon. And of course, in our research, we see that there's some percentage of men. That's why I wanted to share actually here with us, with the viewers, that men do get breast cancer. Do you want to comment on that? I mean, it's a small percentage, but it's still there. It exists. Anyone can take it from you guys?
I mean, I can quickly say that, 1% of breast cancer is diagnosed in men. And in the past 2 months, I've had two new consults that were men with not just small tumors, but with locally advanced tumors, with numerous like stage 3 breast cancers. And so men also need to be vigilant. And unfortunately for men, their concerns, they're not getting mammograms, obviously, and their concerns about a breast mass may be dismissed dismissed a little bit before it's looked into. I don't know if Dr. Stewart wants to share her experiences.
Yeah, I echo that, because all the pink ribbons and all the pink stuff and all, Pinktober that we see, we really concentrate on women. And so men, which I've had a man recently, and interestingly enough, nobody in the system really looked at him as it was even cancer. He came to me from his doctor thinking it was just like a cyst, like a sebaceous cyst. So I think we don't have enough awareness about it. And then I think men who are diagnosed with it feel some bit of shame, because many of our spaces that we built for breast cancer, they're pinked out and they're, frilled out. So now all of a sudden they're going into the mammogram suite and there's, flowers everywhere. And they're coming to these spaces where mostly women frequent. I think that a few years ago, Beyonce's father was diagnosed with breast cancer. And I think he brought a lot of, well, not maybe a lot, but some exposure to it. And I think the more that people bring, knowledge and awareness and allow men to feel like it's okay to have it, it's okay to be checking for it, I think that we can acknowledge that more. But your Dr. Moore is exactly right. Only 1% of men are going to have this disease, but when you're that one, it's 100% to you.
That's true. That's true. Yes, I wanted that because recently I had a man who had a scare. Thank God his mammogram came back negative. So you know what, ladies, thank you so much for this. This was empowering. And of course, to our viewers, as you can hear, everyone is at risk. We're starting to see, actually, my youngest patient that had breast cancer was 24. That was 10 years ago. I couldn't believe it. That was 20, and there was no even risk. And with the things, the environmental factors we see out there, there's so much now that is carcinogenic out there. So we need to watch out for ourselves. As we wrap up, I'd like each one of you to share how to find you guys. And of course, whatever last word you want to share with my community here as we close. Dr. Edith, you want to go first?
Sure. I'm Dr. Edith Stewart, and I practice in the Central Valley. The name of my group is Premier Surgical Group, and I can be reached at ewstewart@Premier Surge Group, and be more than happy to answer questions, or if someone has advice or suggestions for me, I'm all ears. Thanks for having me, Dr. M.
Thank you so much. Dr. Moira, you want to go second, please?
Sure. So my name is Moira Rushton. I'm a medical oncologist. I specialize in breast cancer based in Ottawa in Canada. And if you have any questions about treatment or things that you're interested to discuss further, I'm happy to be reached by email at mrushton@toh.ca. Thank you for having me today, Dr. M.
Thank you so much. Dr. Susan.
I'm Dr. Susan Maltzer. I'm in Long Island, New York at Northwell Health. Also happy to answer any questions. My email is smaltzer@gmail.com.
Thank you so much. We lost Dr. Angela there. She was struggling with internet. Thank you so much for doing this, ladies. And to our viewers, as you know, October is breast month, basically awareness month. We continue to talk about these conversations, as difficult as they are. And I'm glad that my colleagues have spoke extensively, obviously. And of course, they didn't forget mentioning men. As Dr. Edith was saying, men are forgotten. And I think it's our challenge now, us as physicians, to create these spaces, these discussions for them, and also the appearance of the spaces where they're going to go, right? So it has to be gender neutral. There's so much that is happening now. The shift needs to happen. And again, thank you so much for this discussion. I'm going to leave properly your contacts here, how you guys said it, and then people can contact you. Thank you so much for doing this for us. We're going to come back here, viewers, next time. I have comments from you guys. I'm not sure if you have time for this, because I know that people are so busy, but wonderful people who are just checking in, telling us where they're at. Thank you so much, and God bless. Enjoy your weekend.